So this is continuing with digestive disorders. Digestive disorders of the oral cavity right now. So this is all about the salivary glands. So salidinitis is inflammation of the salivary glands. It could be infectious or it could be non-infectious. Most common infectious one, especially of the parotid, is the mumps. It's a virus. It used to be very, very common. Now with vaccination, it's not so common anymore. Most kids get the MMR, and the M stands for mumps. So we don't see it near as often as we once did. The mumps can be unilateral. Most often it's unilateral. It can be bilateral. It can include other things other than the parotid, so like the submandibular salivary glands, etc. And it can also include the testes, so you can get an orchitis from the mumps as well. When I was in grade 2, I had it bilaterally and an orchitis at the same time. It was a hell of a Christmas that I shall never forget. Non-infectious versions of it happen because of dehydration or inadequate fluid intake. So what happens here is the production of saliva goes way down as we try and conserve water when there's inadequate fluid intake. And the saliva concentrates and can form stones. And if a stone forms and it blocks the duct, then the salivary gland blacks up and gets inflamed. And the salivary glands can also get a carcinoma because they are glandular epithelium. So cancer is not unknown. So here's a picture of somebody with the mumps, a unilateral. This is the other side, obviously. So dysphagia is difficulty swallowing. It can be because of neurological problems. We'll discuss some of these specifically, but basically you can't coordinate all the activity that's involved with swallowing. It can be muscular disorders that the muscles aren't responding correctly, so muscular dystrophy can do it. Or it can be mechanical obstructions, so either strictures, scar tissue, tumors, things like that. Dys means difficult or painful, phagia, to eat, to swallow. So pain in swallowing is the part of the presentation. Some people can't swallow larger pieces of solid material, but they can do smaller and liquid. And it'll run all the way to people that can't do liquids. So the neurological deficits really could be stroke, brain damage, could be infection that is affecting the nerves. Achalasia is when the lower esophageal sphincter doesn't open. And now that can be held closed and not open because of a lack of innervation from any of the things above. Muscular dystrophy is the big one that we worry about for swallowing disorders, but it can be other neuromuscular disorders can affect swallowing as well. A congenital atresia is the upper part of the esophagus and the lower part of the esophagus don't meet. If you remember from physiology, the upper part of the esophagus is skeletal muscle, the lower part is smooth muscle, and the middle part is a mixture of both. Developmentally, one grows up from the stomach, the other grows down from the pharynx, and they meet and they fuse. If that doesn't happen, you have a congenital atresia. This doesn't affect a baby in the womb because they don't eat. However, once it's time to feed, this is not a good thing. Stenosis is narrowing of the esophagus. Could be a developmental thing where it just doesn't grow properly, or it can be acquired. Usually it is acquired, and usually it's secondary to some other problem, like chronic inflammation from GERD, gastroesophageal reflux disease, ulcers, fibrosis, radiation for lung cancer or for any other tumors can scar the lower esophagus, and that causes a stenosis. The simple way to deal with it is to literally just put like a balloon in and expand and mechanically dilate. Sometimes surgery has to be performed. When we talked about diverticulosis in the last video, we were talking mostly about the colon, the large intestine. But it can happen anywhere along, diverticula can happen anywhere along the gastrointestinal tract. And a reasonably common place for it to happen is in the esophagus. And this is when there's an outpouching of the esophageal wall. Now, again, it's usually acquired, but it can be congenital, where it just grows with a little pocket. When it happens, it can get irritated and become a diverticulitis sort of thing. And then that inflammation and some scar tissue will happen. Now, the biggest problem is that in the esophagus, it holds food in the diverticula, and that food ferments and leads to very, very foul breath. A distant relative of mine, like a cousin of my grandmother's, he had an esophageal diverticula congenital. And I thought this was so funny when I was a little kid. They called him Stinkin' Ernest. His name was Ernest, his name Ernie, and I guess his breath was pretty foul for his whole life, and that's because of this diverticula. And so every time I heard him referred to, he was Stinkin' Ernest, which as a little kid I thought was the funniest nickname ever. He probably didn't find it so funny. Tumors can cause mechanical obstructions. So a tumor of the esophagus itself causes stricture, or a tumor outside, anywhere in the mediastinum, can close down and just push against the esophagus. So fibrosis and strictures here, compression from like a tumor, this one would be outside. This is kind of a diverticula, a pouch filling with food and obstructing. This is what atresia looks like. There's a gap. We can have fistulas happen. Neurological damage, especially to various cranial nerves. This is the sphincter not opening, and the food builds up here. The esophagus can get cancer. It is a squamous cell carcinoma because the mucosa of the esophagus is a stratified squamous epithelium. It usually happens in the distal esophagus because that's where most of the damage happens. If there's gastroesophageal reflux disease, GERD, the damage happens there, the inflammation happens there from stomach contents coming up, hiatal hernias, that kind of thing. If there's chronic inflammatory damage, we call it a Barrett's esophagus, and this can lead to esophageal cancer. As we've already discussed in other units, chronic recurrent irritation causes histological changes which can lead to cancer. The problem with this is that the symptoms of this cancer are pretty much the same as the symptoms of anything that is precancerous as a lesion, and it probably has been investigated, etc. So it's often ignored. Not only is it ignored by the person who thinks, oh, Jesus, this is more of the same, that I have acid reflux and I've had it for years. And so this pain is something I'm used to, it's just more often. And family doctors will be, well, no, you have acid reflux. Here, up your Tegamet, up your medication. And so by the time they actually get around to diagnosing it, is a very poor prognosis. It just happens that way. So it's associated with this chronic irritation. So chronic esophagitis, so hiatal hernia and gastric reflux, achalasia, where it's not opening and the food sits and doesn't go down into the stomach for a while. Alcohol abuse and smoking. Honest to goodness, I think that if you look for causes of anything, alcohol abuse and smoking will be on that list. Doesn't matter what it is. Okay. Hiatus hernia, very, very, very common thing. And this is where normally the esophagus passes through the diaphragm, through the esophageal hiatus. And the diaphragm is a muscle that surrounds that. The stomach is right below. In the abdomen, the esophagus is in the thorax. If that opening, that hiatus, rips, it's now going to be called a hiatal hernia. And what can happen is, especially if there's any pressure on the abdomen, the stomach will push up and protrude through that hole. And it ends up just the top part of the stomach, right around the cardia of the stomach, will end up above the diaphragm. This is called a sliding hernia. So the stomach can slide up to above the diaphragm. If the hiatus hernia gets really big, then part of the fundus of the stomach can move up to the diaphragm, and then that becomes really difficult because it becomes trapped up there. So normally, esophagus on one side, stomach on the other. If the hole gets too big, then part of the stomach can end up above. If it traps up there like that, it's the paraesophageal. So what are some of the complications of this? One of the things is that food can lodge in that pouch and cause inflammation of the mucosa. Now, the stomach contents are very highly acidic. Lots of hydrochloric acid. The stomach can handle that because it's coated in an alkaline mucus. The esophagus can't handle it, and so it burns the esophagus, and so you end up with esophagitis. If it happens often enough and for prolonged enough period, you get chronic histological changes, Barrett's esophagus. What you feel is heartburn, lots of belching, increased discomfort when laying down, because when you lay down, the stomach pushes up against the diaphragm and can come through. If it gets really bad, you get pain behind your sternum, and you can get referred pain to shoulder and your jaw. Usually it's the right shoulder, but it can be the left shoulder. But if it goes to your jaw and your shoulders, and the pain is right over your heart, a lot of people think that they're having heart attacks from it. Hiatal hernias are difficult if you're bending forward, and that puts pressure on your abdomen, and it pushes the stomach up. So cleaning a bathtub, for instance, is very difficult. And this is related to GERD, gastroesophageal reflux disease. So this is periodic reflux of stomach contents into the esophagus. You get erosion and inflammation. Sometimes people get it without having a hiatal hernia, but it's often seen together. So it's really an incompetent lower esophageal sphincter. So stomach contents, you kind of almost barf a little bit up into your esophagus. One of the big things is delayed gastric emptying for whatever reason. We get delayed gastric emptying if you've been drinking, if you're really stressed. Those both are big things. You got to be very careful about eating really late and then going to bed, because that's not good. You should avoid caffeine because that stimulates acid production in the stomach. Any fatty or spicy foods stay in the stomach a long time. Spicy foods stimulate a lot of acid production. Alcohol and smoking, there's a surprise, and various drugs, especially aspirin and the non-steroidal anti-inflammatory drugs. So what we do is we use various medications, stop as much acid production, and we use anti-inflammatories. Sometimes the stomach lining itself gets inflamed, and this is called gastritis. Now we can have acute gastritis and chronic gastritis. So acute gastritis is the mucosa is inflamed. It can go all the way to a bleeding ulcer, but usually it's just an inflammatory patch within the mucosa of the stomach. Often the result of infection, food poisoning, microorganisms. Sometimes it's allergies to food, so that might be if you're celiac and you have gluten. Spicy or irritating foods will do it. As you start eating some ghost peppers, you might get some inflammation in the stomach. Alcohol will do it. Alcohol gets absorbed through the stomach, not through the intestine, and so it's pretty hard on the mucosa. It also damages the protective mucus lining. Same thing with aspirin. Aspirin more than the other nonsteroidal anti-inflammatory drugs, but nevertheless, they get absorbed through the stomach. That's one of the reasons why we take enteric-coated nonsteroidal anti-inflammatories to try and get them past the stomach and into the intestine before we absorb them. Some people ingest corrosive or toxic substances, like drink bleach, that kind of thing. Radiation and chemotherapy are both really hard on the stomach. Remember that radiation and chemo both target cells that are actively undergoing mitosis. And the stomach mucosa is constantly undergoing mitosis because the environment is so damaging that those cells are being replaced constantly. So when you have this, you don't feel like eating, because if you eat, you will produce more acid and you'll irritate more. So anorexia is huge. Nausea and maybe vomiting. Vomiting up blood if the inflammation causes ulceration and bleeding. You get epigastric pain. So this is the middle of the upper of the 6 quadrants. Cramps, etc. You may end up with diarrhea. This is the classic food poisoning type diarrhea where you're puking on one end and pooping at the other and you don't know which end to put over the toilet. It's usually self-limiting, but you might need antimicrobial drugs. You might also need supportive treatment. So if you've got prolonged vomiting, people will dehydrate, people will end up in a metabolic alkalosis and will need bicarbonates and things. Yeah. So if this happens long enough, we can start to get histological changes, and then it becomes chronic gastritis. So there's atrophy of the mucosa, you lose the secretory glands. A real problem is that you don't produce enough intrinsic factor. Intrinsic factor is necessary for absorption of B12, so anemia can follow. Oftentimes, H. pylori, Helicobacter pylori, is present. This bacteria has learned to live in the alkaline mucus produced by the stomach. And what's interesting about this bacteria is it eats that mucus. That's how it feeds itself, the proteins in the mucus. But the lumen of the stomach is outside of the body, so the immune system can't get at it. And because it's in this protective mucus layer, it's very difficult to treat, to get at it. So we can get these chronic H. pylori infections. I read a statistic one time, and I can't remember what the exact numbers were, but a large number of us, a very large percentage of people asymptomatically have H. pylori. You get some epigastric discomfort, intolerance to certain foods, especially spicy foods, that kind of thing. Could be vague. Increased risk of peptic ulcers and gastric carcinoma. For ulcers or erosions, and carcinoma is from this chronic inflammation. Autoimmune disorders like lupus can be contributing factors as well. Gastroenteritis is when inflammation of the stomach and the intestines. It's usually infection. This is the classic Montezuma's Revenge traveler's diarrhea. Can be allergic reactions to food or maybe drugs. So if you're celiac and you encounter gluten, you can get a gastroenteritis pretty easily. Usually the microbes pass by the fecal-oral route. So that's fecally contaminated food or water. So it's often self-limiting. The immune system deals with it, but oftentimes it's not. It can be very serious if you're immunocompromised, elderly, or taking prednisone, or a transplant patient. We get this in places where hygiene is a bit of a problem. Refugee camps, disaster camps, disaster relief camps, that kind of thing. It used to be a huge problem in armies, like because of encampments. It's like crowded and poor sanitation lead to it. Basically, it's fecal contamination of your food. Dealing with sanitation is how you prevent it. When you're in third world countries, you have to be very careful about the money. Toilet paper is potentially a luxury in a lot of places. People use other methodology. There's not necessarily running water to wash hands and that kind of thing. And so the money gets infected with fecal matter. And if you handle money, you're buying food, you get money out, you pay for it, you get the change back, you handle it, you put it in your pocket, and then you eat the sandwich with your hand, you can get this. I got it one time in Mexico from swimming in the ocean and kind of getting tumbled by some waves, and had a near drowning and swallowed a lot of seawater with probably Puerto Vallarta's sewage system going directly into the ocean. Who knows? Nevertheless, you know where we're going with this. So here's some different transmissions, different things, staph and E. coli, etc. This is one of the reasons they close beaches when the fecal coliforms are high. So what I got in Mexico was an amoeba, so it was entamoeba, a protozoan parasite. Yeah, it was not a fun thing. E. coli normally is a harmless resident, part of the flora and fauna of your intestines, but there are strains that are virulent. The infective strains tend to be named for what they do, so enterotoxigenic, release toxins, enteroinvasive, enteropathogenic, etc. Enterohemorrhagic will make you bleed. So the ulcers, the biggest thing here is H. pylori, Helicobacter pylori. It usually happens in the proximal duodenum, and that's because there is less mucus protection of the endothelium in this area. You can find them in the antrum of the stomach as well, and anywhere in between. So what happens is the mucosal barriers, the mucus barrier, gets eroded away because of the H. pylori. And so then we have less defense. So the stomach can auto-digest. The pepsin will start to digest the proteins of the walls of the stomach itself and cause an ulcer, cause an erosion. In the duodenum, it's usually because of the acidity being too much, and it irritates and causes erosions in the duodenum. So it's usually here and can be in here as well. So what happens is we have less defense, and we can have an inadequate blood supply. So one of the things that stress and sympathetic innervation does is it shuts off the blood supply to the GI tract so that we can divert that blood to skeletal muscles and other places. So if you're stressed, you're getting less blood and less nutrients to the stomach itself, which lowers its defenses. Smoking, any sort of circulatory impairment, like shock, anything like that, anemia, interferes with the epithelium being able to repair itself. And so the damage doesn't get repaired and can grow. Excessive glucocorticoid secretion, so that's the stress hormone, so we're talking cortisol, or prednisone can do it, right? Aspirin, alcohol, and other non-steroidal anti-inflammatory drugs break down the mucus layer because that's how they get absorbed. Chronic gastritis, all can lead to it, right? So, so anything that increases the acid secretion, so too much gastrin, too much vagal stimulation. The vagus nerve is parasympathetic, so it causes secretions in the stomach. Increased sensitivity to that. A genetic anomaly of too many secretory cells of acid. Alcohol, caffeine will stimulate more acid, right? Those sorts of things. So if you get a peptic ulcer, one of the real big complications is hemorrhage, because the ulcer will go right through the mucosa into the submucosa and start to erode away the blood vessels, and they will start to bleed. And you end up puking up blood, you're bleeding into your stomach. It's common. Oftentimes, puking up blood is how these things are found. It scares the crap out of people. If it gets bad enough, it can perforate right through the muscularis externa layer and right in through the serosa. And if the stomach contents get out into the peritoneum, you can end up with a pretty bad peritonitis. After, you can end up with obstructions. So especially in the duodenum, you can end up with strictures because of scar tissue and difficulty passing things through. And so it's usually some sort of epigastric burning, pain, that kind of thing. We look down with a scope, we do barium x-rays, we do biopsies to see what's happening there. We treat it by trying to get rid of the H. pylori and to to decrease the amount of hydrochloric acid that's produced. And hydrochloric acid is produced by protons, hydrogen ions, and so the proton pump makes the acid. Inhibiting that means less acid. Physiological or psychological stress can cause it. So if you're burns or head injuries, hemorrhage, rapid blood loss, that kind of thing, we can end up with these stress ulcers. The biggest difference between that and the gastric duodenal ulcers is that they're usually small and there's multiple, and they come on really, really, really quickly. It's usually some sort of physiological stress, though. And all it does is it throws out the homeostasis that protects the stomach. Here's somebody that obviously didn't make it, judging from the fact that they've dissected out the stomach with all the multiple stress ulcers here. The epithelium of the stomach is almost entirely glandular, and so gastric cancer can happen because of mucus glands. It's usually in the pylorus, the antrum. It starts in the mucosa, into the submucosa, but it starts then later to erode into the muscularis and invades that way. And if it invades into the serosa, then we start to get metastasis via lymph nodes. Again, this is one of those cancers that the symptoms are not radically different from symptoms that the person has probably been experiencing for some time, or is easy to explain away by other things. And so it doesn't get investigated very early. And so prognosis is poor because it's usually caught late. It seems that smoked foods, the nitrates and nitrites that are in smoked foods, may play a role in turning the gastritis into cancer. There might be a genetic predisposition. Likely that's the case, that genetics load the gun and environment pulls the trigger. Symptoms are really too vague, so it's a very low survival rate because it's found late. Okay, dumping syndrome is an interesting thing. This is when things leave the stomach before they're adequately mechanically or chemically digested. It goes into the duodenum too early. And this can happen because of problems with the stomach. Oftentimes it follows gastric resection. A lot of people get resection for weight loss and things. The big problem with it is that is not only the lack of nutrition, but this stuff is hyperosmotic. It hasn't had a chance. And because it's hyperosmotic, it draws fluid into the lumen of the intestines. And when that happens, it's taking fluid out of the bloodstream. So you end up with decreased blood pressure, and this extra fluid increases the intestinal motility, which means that you reabsorb less. People get fainting, like syncope, and etc. So what happens is you eat and then it passes too quickly, and then you get too much, so you get abdominal cramps, diarrhea, nausea. Blood sugars drop because insulin secretion goes way up, and the sugars don't get absorbed, so you end up with a hypoglycemia. The way to combat it is frequent small meals, stuff that's going to stay in the stomach as long as possible, so high proteins. Simple carbs pass through way too quickly and they exacerbate. It resolves over time. New balances are found. Hormonally, you adjust and downregulate and that kind of thing. I had a patient who had pancreatic cancer. She was given 6 months to live, and 7 years later she was still around, but for the last year she had pretty bad dumping syndrome. Now we're resolved by her passing away, but that's another story. So she ate constantly, just a bite here and a bite there. Like, she grazed all day long, because if she ate a full meal, it was agony for her. A little chart of this. Pyloric stenosis is something that is going to cause the pyloric sphincter not to open, to be obstructed. Could be a tumor, could be anything like that. Oftentimes it's a developmental anomaly, and if it is, so if it's congenital like that, then the baby can't seem to keep anything down, so there's projectile vomiting right away. Sometimes you can palpate a mass, but the baby doesn't get nutrients to the intestine to absorb, so they don't gain weight, they dehydrate, and they're constantly hungry. And they do surgery to remove the obstruction. My first cousin, Marianne, had this, and when she was 2 weeks old, she went to Sick Kids and had this surgery done. Yeah, and that was in 1958, so that was a long time ago. And she was perfectly fine the rest of her life. Well, she's still with us. She's now retired. Sometimes it can come later because of strictures and scarring. It will increase vomiting and persistent feeling of fullness because your stomach doesn't empty. I'm going to end this video here and pick up at disorders of liver and pancreas in the next video.